biologist by training, and I have about close to 10 years of experience in somatic cancer reporting with NGS. So what I'll be looking at today are what are these molecular markers? What are the molecular markers in cancer? How they've evolved over time, and what does that actually mean for molecular diagnostics in cancer like thyroid cancer? So if you look at cancer in general, everybody knows it's highly driven by genetic mutations. It results with the accumulation of mutations in genes over a period of time. Now, as the years have progressed, and as we know more about this, and as we studied more about the tumor biology, what we've managed to do is harness this specific genetic mutations that gives tumor the advantage to grow and try to make it helpful to us in the management of the disease, right? So we've come to associate these molecular markers with different aspects of disease. They can have diagnostic value, they can have prognostic value, or they can have predictive value. And as with everything, it takes time before the data is mature enough for it to move from the purely research setting and the clinical trial setting into the actual clinical use setting. And if you see in the progression of markers for diagnostic and prognostic use, this is very clear. It started off with hematological malignancies, where there are very clear associations, and all of these associations for molecular markers are in the guideline level and are in part of routine practice. In solid tumors, however, it's a little slower to catch up. And diagnostic and prognostic, there are some very key use cases, but what has taken off more recently, very quickly, I might say, in these last 2 to 3 years is the predictive use for all of these molecular markers in predicting use for targeted therapy, right? In the last 2 days, we've had some wonderful sessions where we've spoken about many of these drugs and their uses in specific situations. And as you can see, this is just a representation of 2019 to 2020 and a little bit of 21. So you still have the whole of 22, where you had many more marker-specific approvals that have shown up for all of these targeted therapies. Now, this is not just something that is at the marker level of a single mutation, BRAF V600E, for example, right? It's very well known. Even in thyroid cancer, it's something that's been around for a very long time. But approvals as such for a marker-specific started off with melanoma, then moved to lung, colon, and now there is a pan-cancer approval. So it's taken quite a bit of time for it to reach to the level where there is sufficient data and sufficient trials looking at cancers for mutation-specific analysis to achieve this end. Now, not just specific mutations, but you also have markers which are at an exon level, markers which are at a gene level, and something even more. So you've got broader signatures. You've got signatures of TMB, which is just a general mutation burden, right? You've got pembrolizumab approval for that. You've got not just small single point mutations, you've got indels, we've got translocations, copy numbers. So slowly the field is moving towards looking at the importance of multiple different types of molecular markers in multiple different genes and across multiple different cancers. Olaparib, for example, BRCA mutations, everybody knows about it, and it's across cancers. It's relevant in breast, ovarian, pancreatic, prostate, right? And then there are, at the other end of the spectrum, are multiple drugs targeting the same molecular marker in one cancer. Clear example is ALK in NSCLC, where you've got 5 drug approvals. And even in thyroid cancer, if you look towards the end of 2020, there were marker-specific approvals for RET fusions. Right? So in thyroid cancer, initially, the well-known markers, right? So over time, when you look at the evolution of our knowledge on thyroid cancer, initially, we had enough of understanding and analysis for BRAF mutations, for RET fusions, or PPAR gamma fusions, right? And all are, and these are seen across different subtypes of thyroid cancer. And also more recently, as the research has progressed and as people have started including larger panels in their study, we find that we understand more about the tumor biology of thyroid cancer. And we know that the classic pathways that are activated in it that give the tumor the advantage to grow are BRAF, MEK, ERK, which is the RAS pathway, as well as the PI3 kinase pathway. So these are the two major players. And as you can see down here, there is also mutations not just in BRAF and the RAS proteins, but also in PI3 kinase that has come up more recently, and studies are looking at that as well. So as this progresses, we're finding that there is more to be understood, and not every marker is a marker that can be targeted with a specific therapy, right? There is also the other angle that we have to look at of a diagnostic nature. If a marker is specific enough for a particular tumor, can it be taken that the presence of it is indicative of malignancy, right? So that is one important aspect that I think has evolved quite nicely. If you look at the history of molecular diagnostics in thyroid cancer. So with FNAC evaluation of thyroid nodules, right, and the classification of the Bethesda system for reporting thyroid cytopathology, we have 6 levels of categorization, 6 different categories, right? Starting with the non-diagnostic and benign categories and ending with the suspicious for malignancy and the malignant categories. Now, these 2 categories are quite clear. We'll know it's very clear what needs to be done when it's benign, very clear what needs to be done when it's malignant. The intermediate categories of ATP of undetermined significance or of suspicious of a follicular neoplasm. So there has been a considerable amount of research done over the years from around early 2000s till a little later towards 2020-ish. In this time frame, what has been done is to try and find a way to further stratify the patients in these categories, right? Using multiple different means to be able to identify those who do not require surgery, right? Who can be classified more into the benign stage, because it's to avoid unnecessary surgery in individuals, and also on the other spectrum to see if there are any other ways of finding a malignant tumor without any characteristic mutations. Now, we've spoken about in the previous slide, we looked at all the different mutations, RAS, and we've looked at RET fusions, etc. Now, these are not seen in all the tumors, right? There are specific drivers for specific tumors. So what can be done in terms of molecular testing in order for us to help stratify all of this? I'll show you a specific slide going forward, but what that has actually resulted in, or at least as far as the Bethesda classification goes, is the inclusion in the 2017 revision, which is the second revision of the guidelines. This guidelines included molecular testing as an option for categories 3 and 4 in order to further identify the risk of malignancy, right? To further get that information and then decide on the clinical way forward. So this is what goes hand in hand. If you look at the Bethesda guidelines that started off initially versus what it ended up in 2017. Now, this progression here is just a peek at one specific study, a well-known study in thyroid cancer, well-known assay per se in thyroid for ThyroSeq. This looks very nicely at multiple things. So if you started off, you can see initially B0, the very first version, started off only with 7 genes. Then it moved forward. And as more information came up in the different levels of analysis that were done, it included 13, 56, and then 112 genes in the latest V3 version of ThyroSeq. Now, this was made possible because of 2 things. One is more number of trials that are evaluating molecular markers, plus more number of, not more number, a better improvement in the technology available to assay these mutations, right? So most of these are present at very, very low level in the tumors, and they're spread, and they are spread across multiple genes. So as a result, all of this progression and all of this increase in technology has allowed it to reach a stage where, if you see initially, the negative mutation status had a risk of malignancy of 6%, which over time has been brought down to 3%. So 3% is your chance of malignancy if it is a negative status. So work has been done in order to ensure that a negative result of this test is a true negative, and that the patient only requires, can be treated as a benign and does not have to actually undergo surgery or have high risk of malignancy. Similarly, you can look at the positive predictive value as well. A mutation positive, how much or how many % of it actually could mean a disease and would require further treatment, has also increased but plateaued after a certain stage because the focus was shifted to reducing the mutation negative risk of malignancy. Other tests similarly that have developed over time are the Afirma gene sequencing classifier and uh, Thyroid and Thyramate. Now, most of the studies as they progressed did not look only at mutations, but tried to bring in other molecular markers in order to help identify, stratify things a little further. So using expression analysis for genes, using copy number variations, fusions, anything possible in order to achieve that little bit of a difference. So once this is done, the nodules are evaluated and we've decided whether we need to proceed with surgery or with RAI, what the clinical progression should be like. The next aspect of molecular markers comes in for the predictive aspect. So that's the other role of molecular markers in thyroid cancer. Now, the predictive aspect comes in metastatic disease. It comes in either in later line and with more increasing evidence, maybe little earlier line as well. And this started off, this also has a nice, neat progression. If you look, we'd spoken about the RET-specific inhibitors, which recently received approval in the last 2 years. But even earlier than that, if you can see, the other drugs that were approved for this cancer were marker independent. These are multi-TKIs, sorafenib and vantinib, right? They targeted multiple growth factor receptors and therefore are quite effective in treating the disease. Now, this moved on to RET, which became a more specific, targeting a specific mutation, which is seen in high frequency. And also with more recent pan-cancer approvals, gave options of using other markers as well, NTRK fusions or a high TMB, which could then further be targeted with other approved therapies. So in the context of predictive nature molecular markers, there are very clear associations with BRAF, NTRK, RET, very well-known ones. PI3 kinase and RAS are more recent drugs, more recent pathways which are activated, and further research is required before it can reach the level of marker-specific approvals, at least in thyroid. But what about the rest of it, right? Does this encompass all the mutations that you can see in thyroid, or will cancers be driven by some other mutations? Now, this we can look at by looking at other gene panels, right? To see what other markers can drive a cancer. Again, this is at a much earlier stage in the progression of therapy. This is right in the research stage. But over the years, with more advanced research, we'll be able to identify even more targetable markers. You can use smaller gene panels for the diagnostic purposes where you know exactly what you need, or if you need to know direct targetable markers. But if you want to have a more exploratory option, then you have larger panels which include different variant types, such as fusions, just like we mentioned with the Thyroseq V3, copy numbers. All of these give you additional avenues for opting for different treatments. The only caveat there is that if you're analyzing a large number of genes, you need to have not only the technology to evaluate those genes, but a subsequent technology to interpret the results of those genes, right? Because not every mutation, as we know, that's seen in a tumor is actionable, or every mutation is even clinically or functionally significant, right? So with a smaller panel, you get typically some 20, 30 mutations. With a larger panel, you can get up to hundreds of mutations. So the ability to weed down the mutations to significant ones arrives by looking at a focus of the specific genes that are driving that cancer. We know the pathways that are active in thyroid cancer, a specific look at those pathways, and a further look at what are the types of mutations known in that pathways. There are plenty of software available, plenty of databases which have annotations which can be used. And all of these things will be used to stratify similarly the variants seen, to be able to look at the specific variants that are likely to be driver mutations in a cancer. The passenger mutations may not have such a large contribution and may not benefit from being targeted. And the benign mutations are some things which are completely not affecting the tumor at all. So we need to be able to make this distinction. So here you can see PI3 kinase, one of the genes which is quite frequently mutated in thyroid cancer will come to a top of a list of this type of mutations. And here, this is a summary of the frequencies of the different targetable driver mutations. A very nice review article, which looks at multiple cancers and gives you an idea about how certain genes which are frequently mutated in a different tumor might not be as frequently mutated in our cancer of interest. But if we do see that mutation, as with recent pan-cancer approvals show, it is possible that we could use this in order to help fight the growth of the tumor. Right. So in summary, in thyroid cancer, molecular markers have two clear roles, diagnostic and predictive. And with the Bethesda revision of 2017, molecular testing for categories 3 and 4 has helped further stratify patients to determine risk of malignancies. And with improved technological advances and increased enrollment in clinical trials and increased data analysis, we could identify further drivers of cancers, which could then move on to getting drug approvals or specific targeted therapy, market-specific approvals that could help in further treatment. Thank you.
Thank you, Dr. Aaarthi. If we have any question, we can take it.
Yes.
What is your suggestion for creating a customized panel for
So it depends on your use case. So if you're looking at specific targeted therapy, then an actionable panel of the genes which you would consider using if you had a positive marker in this, that there is a very relevant therapy or a very relevant disease course that you're targeting, it is possible to look at smaller panels, and that's the best utility as such. Right? The larger panels are very exploratory and have their own use cases in maybe later settings and all of that. But a smaller panel is definitely possible if there is enough of understanding of the biology of the disease, right? And you can have smaller panels that just look at BRAF and certain specific fusions, certain specific pathway markers. I think that it will be helpful if we are sure of the use case and what we're going to do with the mutations in that. That's the main important part in creating this panel.
Another important problem is lack of tissue in anaplastic thyroid cancer. Though it is there are significant actionable mutations, most of the time patient is in stridor and we have to start some treatment without waiting for any biopsy. Any significant role of ctDNA or cfDNA based NGS in this?
Definitely. So for cancers like lung, it's proved very useful to use this. In thyroid as such, there hasn't been so much of explorations for ctDNA. There has been a lot in head and neck using saliva to try and get. So if it is possible to develop a ctDNA, it is very, very useful in situations where you have very less DNA to start off with. That said, NGS now has also improved side by side where it can use lesser amounts of tissue to actually determine it. But other assays that you would go for